That was wonderful, Sophia. But this is also why you can't recruit genetic counselors in New York, because Sloan Kettering has stolen them all. A couple of quick housekeeping issues. The speakers for the afternoon, Dr. Cow, Dr. Hayes, Dr. Wu, Dr. Benaran, and Dr. Perea. We need you to go to the green room to get mic'd for your sessions. Moving on, but staying on the theme of germline genetic variants associated with, or germline genetic features associated with early onset colorectal cancer, it's my pleasure to introduce Elena Stoffel, who is the Director of Clinical Cancer Genetics at the University of Michigan. She is also a gastroenterologist with a long-standing interest in early onset colorectal cancer, and I'm really looking forward to her talk.
Thank you very much for inviting me to be a part of the program today. I think that when we approach colorectal cancer risk assessment, as you've heard, what we focus on is what's the patient's age, what's the patient's family history, and often that's just limited to diagnoses of colon cancer in first-degree relatives, and then what's the patient's personal history. Back in 1996, when I started doing this, this was the vision that we had of hereditary cancer syndromes. We said most of colorectal cancer is sporadic, and probably only about 5% is associated with strongly penetrant hereditary cancer syndromes. This led us to develop algorithms to try to identify who are the individuals with colon cancer who are most likely to have germline mutations. And as you can see here, now our algorithms start with looking at the person with colorectal cancer, looking at the tumor phenotype, and then based on whether the tumor phenotype is microsatellite stable or unstable, we look at the family history and the patient's phenotype to determine whether or not they require germline genetic testing. So what I'm going to present to you today is our look back at how well this clinical algorithm works in the real world, in the changing landscape of colorectal cancer arising, the increased incidence of colorectal cancer in young people. This was a retrospective review of outcomes of clinical genetic evaluations that were performed in patients who were seen at University of Michigan in the Cancer Genetics Clinic between 1998 and 2015. So that's a big time span, and during that time span, our approach to genetic evaluation of patients with colon cancer changed. So to start off here, you can see just basically the characteristics. Interestingly, all of the studies you've heard today, we have about 430 individuals with young onset colorectal cancer. And most of these individuals have microsatellite stable tumors. Only about 1 in 4 have a family history of colorectal cancer in a first-degree relative. And unfortunately, many of them are diagnosed at advanced stage disease. So what happened to these patients? Well, we started off with doing our traditional clinical evaluation, and basically almost a quarter of the population did not proceed with germline genetic testing the first time around because they had microsatellite stable tumors and no family history. But among individuals for whom germline genetic testing was pursued, we identified pathogenic germline variants in 79, or roughly 18%. And as you can see, the usual suspects are represented: the Lynch syndrome genes, APC associated with familial adenomatous polyposis, and a couple of juvenile polyposis genes. But interestingly, with the onset of multi-gene panel testing, we also start finding the BRCA mutations, the CHEK2 mutations, and P53 associated with Li-Fraumeni syndrome. So when we compared individuals with pathogenic germline variants to individuals without pathogenic germline variants, the individuals with pathogenic germline variants were more likely to have microsatellite unstable tumors, and that's because many of those were Lynch syndrome patients. The individuals without mutations were less likely to have family history of colon cancer in a first-degree relative. And those without a family history were much more likely to be diagnosed at advanced stage disease. Interestingly, individuals without germline mutations were more likely to have tumors in the left colon and rectum, as you've been hearing about all afternoon. So what did we do at this point? Well, Many of the patients who were enrolled in this study had actually provided a blood sample, a germline DNA sample for research purposes. And so we went back to a convenience set of the individuals who either had not had germline genetic testing the first time around, or whose genetic testing had been had revealed a negative result. And we actually resequenced these individuals with research-based a multi-gene panel that included 124 cancer genes. And what we found was, we found that approximately 1 in 20 of individuals that had been previously evaluated as having a negative genetic evaluation actually had pathogenic germline variants in genes that were actionable. And interestingly, these included 2 individuals with mutations in PMS2 and MSH6 associated with Lynch syndrome, as well as an MSH2 mutation carrier, P53 carrier, and POL-E and APC mutations. Now, what did these families look like? Well, this was one example of an individual who had a microsatellite stable tumor. This person had been reported to have multiple colorectal polyps. They had undergone germline sequencing for APC and MUT-YH, which was unremarkable. And a multi-gene panel testing identified this individual as having a SMAD4 pathogenic mutation associated with juvenile polyposis. Similarly, this young woman with colon cancer at 36 had a microsatellite stable tumor and no family history, and she actually had a PMS2 germline mutation. Similarly, this young man with colon cancer at 28 had a BRCA2 mutation. So what does this tell us? Well, we know that there are missed mutation carriers out there, and the reason for that is that family history can vary. 48% of our mutation carriers had no colorectal cancer diagnoses in first-degree relatives. Many of the relatives have not developed their cancers yet, because if the proband is diagnosed with colon cancer at a young age, people may not have gotten their cancers yet. There's also incomplete information and missing information on family history for many of these families. And we also know that penetrance is variable, especially for mutations in MSH6 and PMS2, which can demonstrate more subtle phenotypes and lower lifetime cancer risks. We know that there can be overlap between the different hereditary cancer syndromes. And we used to think of hereditary colon cancer as distinct from other cancer diagnoses. But as Dr. Stadler mentioned, we're seeing across pan-cancers, we're seeing cases of Lynch syndrome. We're seeing overlap with BRCA mutation carriers in Lynch syndrome, or in families that we would have thought looked like colorectal families. We also know that our tumor testing isn't perfect. And while we are doing a really good job at getting pathology programs to screen tumors universally for mismatch repair deficiency, in young individuals, some young individuals with MSH6 and PMS2 mutations may have tumors that are read as microsatellite stable. So what's interesting about our data is that our data matches up pretty well with what you've heard presented earlier today. The prevalence of mutations in individuals, the prevalence of mutations in individuals age 35 is higher. We got to about 25%, which is very similar to what you heard from Dr. Stadler, and it's similar to what was reported by the MD Anderson group by Maureen Mork and company, as well as the prevalence of germline mutations in the under 50 population for us was almost 20%, which is very similar to the 16% that you heard about from Dr. Hampel, as well as from Dr. Stadler. Now, the spectrum of hereditary predisposition to colorectal cancer is really changing. When I started doing this, we knew about Lynch syndrome, we knew about familial polyposis, and we knew about the rare juvenile polyposis syndromes. But since then, since I've been doing this, we've learned about MUT-YH, POL-E, POL-D1, and THL1. And we're also learning that the spectrum really starts covering a lot of the other genes associated with other hereditary syndromes, as well as some of the moderate penetrance genes. So where does this leave us? I really like this figure from Terry Manolio looking at the missing heredity of complex diseases, because what we've spent a lot of time looking at is actually this group over here, the really rare but highly penetrant alleles that are associated with high disease risk. There have been a lot of GWAS studies that have looked in this area that have identified literally hundreds of single nucleotide polymorphisms associated with very, very small risks of disease. But where does that leave us with these cases of young onset colon cancer? Well, I have the pleasure of working with a colleague at University of Michigan, Ji-Yoon Jeon, who has worked who's a modeler and actually works with a lot of the big GWAS groups looking at what factors may be associated with the unexplained colon cancer risk that is not predicted by looking at family history. And basically, in a model that she developed using genetic G-scores calculated using 63 single nucleotide polymorphisms and environmental factors, many of which we've talked about today, she basically found that a model combining G-score, E-score, and family history performed significantly better than family history alone. Now, what we've done is we've actually started looking at our young onset colon cancer patients who do not have a pathogenic germline mutation to see how well the G-score might help us identify these individuals. And while you can see that there is a little bit of separation, it's not great, but I think what's important to see is that a G-score model that uses 63 SNPs performs with an AUC of 56, but when you actually increase the number of SNPs, you actually get a better predictive model. So I think, where does this leave us here? I think that what we're spending a lot of time talking about today is the fact that there are other factors playing a role here. And there may be a role for looking at combinations between common genetic factors and common environmental exposures that may have interactions. So in conclusion, hereditary cancer syndromes in our study were diagnosed in roughly 1 out of every 5 individuals with early onset colorectal cancer. The multi-gene panel testing for all colorectal cancer under the age of 50 definitely increases diagnostic yield. And however, the majority of early onset colorectal cancers are not associated with highly penetrant hereditary cancer syndromes. And that's why looking at, it's going to be important to look at genotype and lifestyle data and actually be able to combine that with some of the information that we've been able to get from genome-wide association studies, which may provide us with information about not only risk for colorectal cancer, but mechanisms of pathogenesis. Thank you very much for your attention.